Assalamu alaikum. Should we be considering prescribing corticosteroids for patients presenting with acute sore throats? Corticosteroids has been widely used to reduce inflammatory reaction in many conditions, both locally as well as systemically. It has been tried to reduce upper aerodigestive tract inflammation, including inflammatory diseases in the lungs and in other parts of the upper respiratory tract like acute sinusitis or otitis media. And of course, we use it already for short-term relief of the symptoms of sore throat and throat swelling in glandular fever, infectious mononucleosis. The mainstay in the management of acute sore throat are antibiotics and analgesics. We know that antibiotics would significantly improve patients' symptoms at day 3 and day 7 compared to a placebo. At day 3, you would expect only about a third of the patients on placebo to have symptoms resolution, whereas patients who are on antibiotics, more than half of them would feel better. On day 7, the ratio would be 87% symptom-free for the antibiotics versus 82% for patients who are on placebo. The numbers needed to treat may be up to 21 patients to get this beneficial outcome. Overall, antibiotics would shorten the duration of symptoms by about 16 hours over 7 days of acute sore throat. The question is, would adding corticosteroids be beneficial, either adding or substituting it to the antibiotics? The Cochrane Review 2020 was designed to answer this question. It is basically an update of the Cochrane Review on 2012 on the use of corticosteroids in acute sore throat. They added one new trial, randomized controlled trial with a large number of patients. So the total is now 9 trials involving 1,319 participants, some of them children and the majority were adults. Most patients would receive either a single dose of steroids or a placebo, but in some trials, in 2 trials, some patients received 1 dose of corticosteroids and others received more than 1 dose of corticosteroid to see if increasing the dosage would be helpful. In 8 trials, the patients had corticosteroids in addition to antibiotics. In 1 trial only, there was 1 arm for corticosteroids and an arm for a placebo with no antibiotic given routinely. And the main outcome was this: resolution of pain. In addition to any effects of the antibiotics and the analgesia on the pain score and the pain onset, steroids had actually worked. It increased the likelihood of complete resolution of pain at 24 hours by 2.4 times. 2.4 times of patients on steroids have a chance of complete cure and resolution of pain compared to those who had not had the corticosteroids. And at 48 hours, the ratio is a little bit less. It's still 1.5 times that of a placebo. What is of significance here is that the numbers needed to treat to provide this effect are just 5 people. 5 people would need to be treated to prevent 1 person continuing to experience pain at 24 hours. This is the meta-analysis summarizing the results of the trials on complete resolution of pain at 24 hours. The outcome measure was the risk ratio, and this side it favors the corticosteroids and the other side favors the placebo. And you could see 2 subgroups, one for the oral corticosteroids and the other for the intramuscular corticosteroids. And you could see a clear reflection of an effect here. Corticosteroids was more effective in reducing pain than placebo in various degrees. Intramuscular injection is obviously more effective. The net effect is that those patients on corticosteroids have more chance of having complete cure at 24 hours, 2.4 times those who have only a placebo. That is the same pattern in the second meta-analysis to investigate complete resolution of pain at 48 hours. And you would see the same pattern here and a clear indication that corticosteroids were more effective than a placebo, but this time the effect size is 1.5 times only. Now, in addition, there were other secondary outcomes. Corticosteroids reduced the mean time to the onset of pain relief by 6 hours. Patients taking steroids started to experience pain relief 6 hours earlier than patients on the placebo, and the same happens for complete resolution. Patients on steroids would have complete resolution of pain 11.6 hours earlier than patients with only a placebo. At 24 hours, pain as judged by visual analog scales, the severity of pain is reduced more compared to a placebo by at least 10% in the corticosteroids group. There were no differences in the adverse events between the two groups, no difference in the recurrent or the relapse rates between steroids and placebos. The number of days missed from work or from school are just the same in the two groups as well. And this is the meta-analysis showing the mean time to the onset of pain relief compared between the steroid groups on this side and the placebo on the other side. And you could see clearly that the corticosteroid group are favored. The average duration is about 6 hours earlier on the steroids group than compared to the placebo group. And this meta-analysis shows the other secondary outcome of reduction in the pain severity as judged by a visual analog scale at 24 hours. And you can see the corticosteroids group on this side and the placebo on the other side. And generally speaking, the corticosteroids group had better results with on average 10.6 reduction in the pain severity after 24 hours. What is interesting here is that one of the major studies, the Haywood 2017, which accounts for about 50% of the weight of the whole of the meta-analysis, actually showed the reverse pattern. It showed that placebo had less pain severity at 24 hours compared to the steroid groups, but the final outcome of all the trials was in favor of patients who were on the steroids. So that Cochrane review, the 2020, on the corticosteroids as a standalone or add-on treatment for acute sore throat was very useful, but there are limitations. Only 2 trials were reporting results for children, and the results of these 2 trials were not consistent, so it was difficult to draw conclusions about the effect of corticosteroids in children. The other thing is that in the largest trial in this review, the patients who have severe sore throat were excluded because it was investigating the net effect of corticosteroids on sore throat pain. So patients were given corticosteroids and a placebo with no antibiotics for the 2 groups. Therefore, we don't really know whether the use of corticosteroids would reduce antibiotic use in people who have severe sore throat or not, and we don't know the benefit for children. The other thing is the trial evidence was not always consistent, as we have seen already, and there was a small number of including studies, just 9, so there is a potential to increase the uncertainty. Another question was this: would you provide these steroids intramuscularly or oral route? And 2 studies were directly comparing the results of the intramuscular and oral administration and found no differences between the 2 routes. But on subgroup analysis of some of the other trials, there was an indication that the intramuscular route would have a greater effect size in at least 2 things. the percentage of patients having complete pain resolution after 24 hours, and they will also start to feel the pain relief a bit earlier than those patients on oral corticosteroids. Of interest here is that this other secondary outcome, the onset of pain relief, was also noticed more in patients who have severe exudative bacterial pathogen positive sore throat. The more severe the sore throat, the more likely they would benefit from intramuscular injection. But the effect size did not reach significance in both these two factors. So the advice at the end was that oral corticosteroids may be more acceptable to patients and appear to be equally beneficial. The question here is whether corticosteroids can be taken on its own in acute sore throats in the absence of antibiotics, and the trial of Hayward 2017 has attempted to answer this, and they did find some improvement in the group of steroids compared to the placebo after 48 hours in terms of pain control. Both groups had not had antibiotics. Mind you, the design of the study was that if the patients are deemed to require immediate antibiotics, that is to say they have severe symptoms or signs, they would be excluded from this trial and started on antibiotics. So we actually don't know whether steroids would be beneficial in patients who have severe sore throats as a standalone treatment or not. We know that it can be of help in patients who don't have severe sore throat. There were no benefits in terms of duration of symptoms or pain severity between steroids and no steroids and a placebo if both patients had not had any antibiotics. So the effect was still modest of corticosteroids in patients who don't have severe sore throat and no need for immediate antibiotics. Further research would be required to establish harms and benefits to permit using corticosteroids as a standalone medication for acute sore throat. Now the question here is, would you prescribe corticosteroids in children? And two trials, the Bullock and the Olympia, had attempted to answer this, but the trials had opposing findings. The earlier trial, the Bullock 2303, found no benefits of steroids on time to clinically significant pain relief or time to complete pain relief between the steroid and the placebo groups. On the other hand, the Olympia 2005 found that dexamethasone actually reduced the duration of sore throat, reduced the severity of the pain, and had an earlier onset of pain relief compared to the placebo. And because only two trials and the results were not consistent, further research is also needed in children before a recommendation about practice can be made. The same conclusion about the effect of steroids on sore throats in children was reached by the Scottish Intercollegiate Guidelines Network later in 2010. There were by that date 3 trials of varying quality of effectiveness, but the evidence was insufficient to support a recommendation in patients with acute glandular fever. That's something else. And with infectious mononucleosis requiring hospitalization, steroids may have a role when pain and swelling of the throat can threaten the airway or when there is very severe dysphagia. The question here is, would you give a single or multiple doses of dexamethasone? And 2 trials had attempted to answer this and again provided some inconsistent results. The Kellerman trial in 2005 showed a significant benefit of 2 days compared to 1 day of treatment, but failed to provide any supporting data. But it was in favor of multiple rather than single dose of steroids. In the following year, another trial found no difference in the outcome between 1 and 3 days courses of treatment. If a single dose is chosen, it's 10 milligrams of dexamethasone in adults, and in children above the age of 5 should be 0.6 milligram per kilogram body weight. This time the question is steroids adverse events. It's unlikely that a single dose of corticosteroids would cause any serious adverse events. All the randomized controlled trials did not report any major event attributed to the single dose of the steroids. This is a moderate quality evidence. But of course, these studies were not powered enough to sufficiently detect minor adverse effects of short courses. 2008, Richard reviewed some of the data on corticosteroids in children and shorter courses of corticosteroids, and suggested that courses shorter than 1 week were unlikely to be harmful. A large meta-analysis of about 44 trials and done for steroids for different reasons, like for asthma, bronchiolitis, wheezes, or pharyngitis, or tonsillitis, but all with very short courses of steroids. In the 44 randomized trials, there was no evidence of adverse events in the steroid group. Out of all the outcomes discussed, these are the 8 important outcomes to the patient: the complete resolution of pain, the time that resolution starts of pain relief, the severity of the pain, whether they would need antibiotics or not, how many days are going to be missed from school or work, and whether the symptoms would recur or relapse, and the duration of any non-tolerable symptoms or adverse effects. So these are the 8 outcomes that would need to pass the test of whether steroids can be suggested or not. The international guidelines varies about whether to use corticosteroids routinely to treat sore throats or not. We have evidence now, some of them high quality, that steroids increase the chance of complete resolution of pain at 24 and 48 hours. It also reduces the severity of the pain and shortens the time to onset of pain relief. You would start to experience pain relief a bit earlier if you are on steroids. On the other hand, steroids are unlikely to reduce the recurrence or relapse of symptoms or reduce the number of days missed from school or work, and the harm seems unlikely because the adverse events are almost not recorded at all in the trials, and the other factor is that the treatment is inexpensive. And now we have the low quality evidence that would make us less confident about the benefits and the harms of the steroids, at least in 2 issues: whether the steroids can reduce antibiotic use, because steroids have been used on its own only in patients who don't have severe tonsillitis or pharyngitis, with some effect, but we don't know whether if the patient has severe symptoms, he would also require antibiotics or not. The other thing is that we don't know whether steroids would reduce the average time to complete resolution of pain. The evidence here is also low quality. And this is the final verdict. There is a weak recommendation for using corticosteroids, but it may be used in almost all patients with acute sore throat. Weak recommendation because of the modest reduction of patient symptoms and the some heterogeneity in the outcomes and the variability in the patient's preferences. May be used in almost all patients, children above the age of 5 and adults, severe sore throat in combination with antibiotics, and not severe sore throat may be as a standalone medication in patients who are on immediate antibiotics and those who receive deferred antibiotics, in patients who have viral or bacterial sore throat, and in patients who seek medical help in emergency settings or in a primary care clinic. By this, we come to the end of this presentation on whether we should be prescribing corticosteroids in the management of acute sore throats. Assalamu alaikum.